Hello, everyone, and welcome back. Like I said, we got a fun one for you today. I knew there's a few in the queue that were coming up, and this is one that I'm excited about. This is the preoperative image the general dentist sent to me. This is one of my favorite guys to work with. He's in a rural area, so he does a lot of root canals himself, but he'll send me the cases that he needs help with, and this is one he did need some help with here. So he tried to help out this patient, get inside there, clean everything out. As you can see, there's a separated instrument. He had a little bit of trouble here. This is what the temporary looks like. So let's go ahead and show you how we're going to get that instrument out and take care of this patient. So first things first, we got to get this temporary out. I do not like IRM. I have said this since dental school, since residency. Everyone's known that. And it just, there's something about it. It's messy. It is a great material for vital teeth. That is the one thing I will say, that eugenol calms down the nerve just beautifully. But if you're going to be working on a root canal treated tooth, or if it's necrotic, Cavit's a much better material, much easier to handle and remove. So the other thing that I dislike is cotton pellets as a space instead of using sponges. So I use endo sponges for any of mine. You've probably seen that in videos before. There's a couple of reasons why. First off, when you try to remove them using whatever the burr is, you're gonna probably ruin the burr. You're gonna have cotton twirled up around that burr, and it's gonna be a nightmare to get off. And this is the second reason why. This dentist is very talented, and he condensed things very nicely. And what that ended up doing means I can't get this stupid thing out. So you saw me there picking at it with the Endo Explorer, trying to pop it out. Now I'm going back in with that big diamond, trying to get it to actually flip up on the burr like we've all seen happen. And it's just not going. So at this point, I'm just going to try to keep doing my access. And what I can feel here is the sponginess of the actual cotton pellet as I'm moving into it. And Jenny's sucking up most of it at this point, thankfully. So there's a little left, but there's actually cotton pellet even going down into the canal. So once I said, very impressive by the dentist to get all of this out of here. So you can see it kind of flipping up there with the air. We almost got the rest of it out. And then I'll use the Endo Explorer here to get the parts out inside the actual canals itself. First thing that caught my eye was that staining back there. I always like to test that. If it is carious, I don't try to repair these through the crowns. For this dentist, I do all of his restorative, and I just have found it to not be predictable to get all of the caries out without taking the crown off. So that's what I was checking there. If that was soft, this crown I would be cutting the crown off and doing the root canal without it there. So at this point, we're going to start going through the process here. And the first thing I notice is that asymmetry in the distal, and you can see that little line. So I'm taking an 8C and poking along there, kind of to see if I can get into anything. I can't, so I will be troughing that in just a minute. And then the next thing I'm poking at here is on the mesial lingual, trying to see if I can't just get around that file right away. Sometimes you get lucky and it's gotten dislodged in the few weeks since they've seen their general dentist. But how I handle these previously initiated treatment cases, I actually find these to be a little more difficult than retreatments in general. And the reason why is because there's usually a reason the general dentist stopped and decided to send it to you. And in this case, it was twofold. They had difficulty finding the mesial lingual and then finally broke an instrument. So if the retreatment was done, and generally at that point they've been able to complete everything, and it's something simple like a missed MB2 that's easy to handle. In a previously initiated case, there's usually a reason that they stopped, and that makes the case more difficult. So what we're doing here is rinsing it out. I like to handle these as if I were going into the tooth for the first time. So I'm going to try to go back through every canal with an 8C, open it up like I would normally, go back in with the 2006, open it up once again normally. And in this case here, I'm going to start troughing along that distal to open up that area that had the little white line to address that asymmetry. Just a reminder, with the exception of a radix or a distal lingual rooted tooth, all NC shapes, all lower molars are symmetrical. So if there are, kind of draw a line through the middle of the tooth, and if the canal is off to one side or the other, you need to trough the opposite side to see if there is an extra canal. This is one of the most common retreats I have to do, is untreated either distal lingual or distal buccal canals, because the presence of 4 canals is a lot higher than you might think. So at this point, I have cleaned everything out, and now we got to address that file. So let's take a look at that file. I took a quick photo here. You can see it is pretty tiny. It's only about 4 millimeters long, give or take, and it is sticking up a little bit. It's not up enough that I can actually pop it up. So what we're going to do is start off here with an ultrasonic. So this is the first ultrasonic I've used on the channel. There are a few more retreats that coming up that I will be using it on, so look forward to that. I like to use ultrasonics from a bunch of different companies, and so this one is from a company called Helsi. They're a Brazilian company, and I've been using their stuff now for probably 4 or 5 years. And I found it to be absolutely fantastic. Their diamond coating is really useful, and the size and shape of their files I use for most of my general purpose root canal. So troughing, things like that, getting files out. I have literally ultrasonics from pretty much every company because I pick and choose my favorite ones. But kind of look around. But this is that E2D is a great general purpose one. So I tried to get it with that. It didn't really pop out at all. So I'm going back in now with my skinny diamond. I found sometimes with these files, what you can do is if you very gently pop them with a rotating instrument, that actually pulls them out. It kind of hits it as if, kind of like when you hit the rubber dam and it spins around, it will sometimes pull it out just by doing that. So what I'm doing here is a combination of the ultrasonic and the rotaries, or the high speeds, just to help kind of knock that thing loose. And you see, you don't want to come straight down on it. You actually want to kind of come at the side and almost brush it up. And if you brush it coronally, that pulls up the file itself and hopefully dislodges it here. So going through, as you can see, just kind of back and forth, back and forth. So this is why, if you've seen my video with my setup, my ASA cart has 3 high speeds, 1 low speed, and 2 ultrasonics. And it's for this reason right here, is I often flip back and forth between a couple different options here, and it's far more efficient to not have to change those out. So at this point, it's pretty much loose. What I'm going to go in through with now is my my EG3 burr, which is a really, really tiny carbide. And the nice thing about this one, I find that carbides, if the diamond doesn't grab it, the carbides seem to work almost better to pop it loose. And what I'm doing here is barely removing any tooth structure. I'm mostly just trying to pull in and kind of tap the side of the broken instrument, and that usually dislodges it. And as you'll see here in a second, it actually has dislodged it at this point. There really doesn't seem to be anything loose or left inside there. So we're going to zoom in here. And you can see I don't see any metal at this point. So now we're going to treat it like this is the first time going into the canal. Start off with that 8C, as you can see, and clean all of that out. So thankfully that drops down pretty readily. It took me a little bit, but right there we're dropped down. Working length on this was right around 20, give or take, and 21 I think actually for the ML. And you can see we are dropped right in there, feeling good. And I'm going to go back and look now when I have my 8C at that distal buccal canal that wasn't treated the first time. So get those all cleaned out. Because it's so skinny, this was a calcified case to begin with. Start off here with the 17. The 20 is just a little big for a case like this. I didn't worry about the other 2 canals starting with the 20 because they had already been cleaned and shaped. It was mostly if a piece of cotton or IRM or something had fallen into the canal in the interim, I wanted to get that out before I accidentally jam it inside there. And so for these skinny ones that haven't been open yet, I'm going to start off with the 1704. So at this point, it's pretty much a regular root canal from here on out. There's really nothing too extravagant. I'm not the best at removing files. I'll admit that right now. I try not to break them, and thankfully I don't really work with a ton of dentists who send them to me. So it's not something I've had extensive experience with. You send me a Thermofill, I'll get that thing out real fast. But with this sort of thing, this seems to be the best technique. I'd love to hear if you guys have a different option as well. So now that we got the 17 done, I'm going in with that 2006. I like to have both the 17 and 2006 to within about 3-4 millimeters of my estimated working length before I go in to actually get the working length. And the reason why is because when you run rotary files through, if there's any curves, you're going to actually change the length of the actual canal when you straighten out those curves. So I like to have most of my filing pretty much done and then just have to work on that final 3 millimeters after here. So at this point, we're going to go to our working length. It's the same thing you see me do every single time. The only difference here is I actually had trouble on the mesial. So let me show you how I handled that. I skipped over a bunch of that because I feel like some of these videos are getting a little long and tedious. They're at least long and tedious when I have to edit them. Let me tell you that much. So what I'm doing here is taking that 1704 down, and you can see I'm short. The final working length for both the mesials is going to be 21 millimeters. And so that is, I can actually feel it drop and become patent. One cool thing is you can use rotary instruments to get length. And so what you're seeing there is the click from my Root ZX, and I can say, okay, we're perfect at the apex right there, going down here as again, and I can feel kind of where the drop is. For mesial canals, the lower molars, they're almost always going to be the same unless there's been some extensive restorative stuff on top of it. So both of these were right at 21 and feeling really good as far as these two go. For the distals, they did end up joining, but there was that second distal as well, so wanted to clean that out. And at this point, we are done with the cleaning, shaping, and all that fun stuff. So going in now to do our final rinse, we're going to use that Triton material as talked about. Still a decent amount of debris coming up here, so I'm going to hit that with the endo activator in just a second, trying to knock anything else loose. But this case, all in all, turned out to be pretty good. It wasn't as infected as I thought it was going to be. The dentist actually called me like late on a Friday to see when he could get her in, and thankfully we were able to get her in the next week, and he got her some antibiotics and stuff for the weekend. But she was in a ton of pain after she saw him, and by the time she got to me, she was pretty much asymptomatic. asymptomatic. So these cases I feel very comfortable finishing. I was able to get it nice and dry. She wasn't in any pain when she came in. So looking good there. So going to use that activator, clean out the rest of it, and just get the process started for the obturation. So as far as the obturation, it's similar to what you've seen in the past, a little bit larger shapes. However, because I was able to control the apical size and keep everything nice and tiny, I am still fine using the squirt technique. You run into issues with that coneless squirt technique when you don't have a solid apical stop, or if it gets above, say, a size 40 or so. There tends to be a lot of extrusion, a lot of sealer puffs that aren't good. I like a little bit of sealer puffs, but enough. You can see the two distals right there, by the way. I'll take a still photo in just a second for you here. And with a case like this, because that apical, even though the coronal aspect was a little bit larger, just because of the file sizes that he used, the apical size was still small enough that I feel comfortable using the squirt technique here. So a couple different photos. I did a close-up here of the actual distal, so you can kind of see what that looks like. So that's where the two canals are. They do join, like I said, but it still is important to clean those out. And then here are the mesials. Really not that bad, and most of that troughing actually was from him. So we were able to finish this case without removing that much more tooth structure. Coming in here with AH+, just like normal. I'm going to recapitulate with the 20K file, also just like normal. So pretty similar to what you've seen in the past here. And then we're going to start the process here of actually going through the obturation. And on this case, the one thing I did do is I didn't initially use the PAC-MAC, and I end up having to use it for the mesials. But the reason why is that PAC-MAC, it's a chainsaw. It is a aggressive file. And if the sizes are larger and you use it like you would normally, you run the risk of extruding a lot of junk out the apex. Ask me how I know this. And so on a case like this that has slightly larger size, I am still fine doing the squirt technique as normal. However, I don't necessarily feel comfortable going straight in with the PAC-MAC because I'm worried about extrusion. So as far as these distals, when they're joined up like this, you can kind of fill them at the same time. It's almost like a type 2 where they come up, but when they're right next to each other, the squirt technique's nice because you can see them bouncing back and forth between the buccal and lingual canals, and that takes care of it, pretty much all the time. You don't have to actually do them separately. So that's kind of nice. And then as far as the other ones, it's pretty much what you've seen me do in the past. Just condensed down with that nice nickel titanium plugger, and that's pretty much it. A lot of people ask me how I do the squirt technique, and really it's a difficult one to teach because so much of it is from feel. And when you're looking at the different canal sizes, you learn over time where you need to push harder and where you need to push less. I know a few people who squirt using something like a calamus or a elements unit, and they seem to like that because it's always the same pressure. I'm actually the reverse. I want to adjust the pressure to fit the tooth. And so on a really calcified case where I just finished it to a 17, I know I can push a little bit harder. Whereas on a larger case like this, I'm going to back off, maybe not put the cannula as far down, maybe not push quite as hard, let it do more of the work pulling me out. So it's what I would say is if you want to start experimenting with this, do it with some extracted teeth and try to play around with different sizes. Don't just finish everything to the 25 or 30 or whatever you want to finish it to, kind of go in. So right now, gutta percha is all done, and what I'm doing is using this metal cutting burr. You saw, I still have no idea how to grab the rubber dam right there. I still have no idea. I like to make things as clean as possible, and I don't like having exposed metal. So she came in clearly with wear in the first place, and we can do better than that. So what I did there is removed the exposed metal, and I'll show you how I block that out. And then I just went in with a diamond here, buzzed off. There's still a little bit of temporary stuff here, and the gutta percha was a little bit sloppy as well. So this is a technique, you have to be careful with this because you can gouge the pulpal floor, but in this case it was large enough and the existing sizes were big enough that they were larger than this tip of the burr, so I really wasn't concerned about it here. When you heat up the gutta percha like that, either with a PAC-MAC or with a diamond, it does do a really nice job of flattening everything off and creating a nice surface you can just push your Centrix tube against when you do the actual build up on it. So, or if the general dentist is doing it. Looking good there. As far as the canals, you can see how much cleaner that looks now that I zapped it with the, and zap probably isn't the right verb, but that's what I call it. And then final thing we're going to do here is we're going to go take an x-ray. It does take a minute for hydrofluoric acid to actually work on there, and it takes us about a minute to do the x-ray. So I found this is a nice time saver to do it right there. There is a void in the mesials, and that's what I'm going to go after here in a second. So at this point, we've already rinsed it off, and I'm just going to take the pack back down both of those mesials just to help kind of, you know, get it a little more solid, make sure that gets out of there. It's high up enough that I do trust the pack back, and you'll see in the final it's pretty much gone. I'm not really concerned about that at all. So we're going to start our bonding process, get this all looking beautiful. But before we do that, we're going to have to pack down that gutta percha from the pack mat because it did pull it up. I do find that the pack mat works a little bit better on those skinnier shapes. I have a 25 is what the tip size is of the pack mat, and on these larger shapes, it tends to almost rip the gutta percha out a little bit more than I would like. So I do know they make larger sizes, but I've made it work. There's other ways to do it, but anyway, going in with a disclosing solution as usual, just getting this all the way cleaned out. I actually think the assistant is doing this. That's why there's no mirror, because I had to grab the air abrasion unit and get that all set up. So that's why it kind of looks a little bit awkward, but we look good. They did a nice job getting it inside the areas that I really I'm concerned about as far as bonding. So we're going to rinse this out. And what I'm also looking for here is any signs that that stained area is caries. So when it stains, if it's a dark blue, that means that the decay has been there, that it's either decay or it's really long-standing bacteria. And you sometimes want to go back in and just refresh that with an actual burr. So you can see there's a little bit of blue on the mesial, just indicating that there's long-standing bacterial activity. The other thing that might be happening here is because IRM contains eugenol, eugenol does attract a certain type of bacteria, and I'm almost on the cases that I do where I'm two-stepping them, I don't see this, where that blue is right around the rim where the IRM was located. And you can see that's where I'm doing all that extra work. I don't see this with Cavit. So I'm almost wondering if the darker color you see, and that's on composite. That's not really tooth structure there anymore. I'm almost wondering if that darker color was from the IRM. Like I said, I don't really use this at all, but looking at that distal aspect, you can see the area under where that white is, that kind of pinkish white, that's composite. And below that is the dark stain. It's still rock solid, no signs of issues. So I'm going to go ahead and just repair this crown for her, save her some bucks. So at this point, we're going to go in with the normal phosphoric acid. I do like to do the phosphoric acid after doing my hydrofluoric. Thank you, Margaret, for discussing this with us at multiple meetings. What happens when you do the hydrofluoric acid is you almost have this smear layer that's created because the acid is so intense, and you actually need to use the normal phosphoric acid to clean that off. So there's still a little bit of metal showing, but it's way better than it was before, and I'm going to be able to hide it almost all the way. With a crown that's this thin, it's really difficult. So we're going to silinate the tooth just because it is a PFM. Want to get that best bond as possible. I hate seeing stains around any fillings when the root canal's been done. It just makes me feel very uneasy. Go in here with the same thing as normal, prime and bond. Actually, my new stuff did arrive yesterday, so I'm going to burn through. I think I just have like a quarter of a bottle left of the old stuff, so I'll let you know once we move over there. I might do a separate review video just on that actual product because hopefully it's going to be great. And then come in with the bond like normal. And pretty much the process is the same as you've seen in the past. Now, I think this is the first PFM crown that I've restored on the channel. What I like to do here is the material I tend to use in the posterior is Build It, and Build It is really, really, really white. It's almost like an opaquer. So I do have separate opaquer that I'll use in certain cases, but one cool thing you can do with this case is when you go ahead and put the Build It inside there, you can almost brush it up onto the metal to hide that area. This works better on, this crown definitely was under reduced when it was done initially because the amount of structure there it's very thin, and the metal, it was an odd looking, the lab did something weird with this one for sure. But you can see I stopped short of filling up all the way, and now I'm coming in with an Endo Explorer to help kind of paint almost along the metal to hide that presence. Because what I do in these is we do the Build It all the way down, or as the core because it's dual cure, and then I finish it with a normal packable composite. In this case, we're going to be using Clearfill. Filtech. I'm switching away from Filtech. I liked it in the past. I have the extra runny stuff, and you'll see it just kind of pools up a little bit too much on the distal. So I have a couple samples on my desk that I've been playing around with. Actually, where is it? Shofu. Has some really nice, beautiful stuff that it seems to be working well. But you can see how that Filtech, I'm mostly putting it on the mesial, and if you look, it's already pulled up extensively on the distal. So this stuff, it flows really nicely, which is cool. The problem is you almost have to go back in and almost cure it as you're shaping it because it flows too well. So I think the product does what it's designed to do. I just am using it in the improper way. So I'm gonna go ahead and cure that and then finish it up here and just do a few final polish things. So as far as this tooth, I'm pleased with how it all turned out. We were able to buy her some extra time of her crown. She had no pain after. We called her the day after and she was feeling great. So I'm really pleased with how this all turned out. With these posts or these files in there, it's hopefully it's this easy for you. Sometimes they're easy, sometimes they're very difficult. So no shade on the dentist. This was not an easy tooth. I'm really happy that he was able to help her out and get her feeling better here. So that would be one recommendation is if you've never worked in a rural area, you don't know how difficult it is sometimes to convince a patient that they need to drive 2, 3, 4 hours to see a specialist. So there's the final. Very pleased with that. Looking great. Files out. Solid fill as far as everything goes. So thank you again for watching. If you have any questions or comments, please leave them below. And then let me know what else you guys would like to see. I have a couple retreat videos that I have started, but I haven't finished the cases. So I don't know if you guys want to see just the how do you open them, but I usually calcium hydroxide all of my retreat cases. And then I do have a couple surgeries coming out that I'm going to record for you as well. But thank you again. As always, drop a comment, like, subscribe, and all that fun stuff, and I will talk to you next time.